patient case. We have a 65-year-old female. She presented to the emergency department with a no ST elevation MI on late of May. And previously she was with progressive angina, and she was currently evolving to CCS3 class. She's her comorbidities are she has hypertension. She's a former smoker. She had about 30 years of smoking, and she had an OST elevation MI in 2014 and had PCI to the right coronary artery with 2 drug-eluting stents. She's on a wide variety of medications, including DAPT. Her labs are pretty much normal, except for her troponin that on the emergency department was 15.7 and went up to 127. And she did a TE on admission. She had preserved ejection fraction with hypokinetic apical and inferior wall. Her EKG shows sinus rhythm. She has a T-wave inversion on lateral wall and a slow R progression on anterior wall. She underwent coronary angiography, and as you guys can appreciate, we have in-stent restenosis on the right coronary artery. You can also see that we have collaterals left system. You can appreciate that we have an occluded LAD, and you can appreciate also that collateral is very good. Her left ventricle, as showed previously on the echocardiogram, has preserved ejection fraction with a slight hypothesis on apical.
Okay, thank you, Zé Henrique. If you could have also the camera with us, please. So, summarizing the case, this is a case that came with ACS and non-STEMI, and this patient had a previous procedure into the RCA for another STEMI with 2 DS there. And I also like to welcome Rodolfo Staik, our senior staff, here with us as well. And a subocclusive stenosis, in-stent restenosis in the RCA, an RCA that gives some collateral to a total occluded LAD. In the very often, it could have heavily calcified and osteoocclusion with some collaterals from bone ipsilaterals and also contralateral. So the patient now is back today to treat the LAD, this osteo total occluded LAD. And I see, Louis, you have a femoral access with 7 French EBU, 3.5. So, okay. So, Louis, what's your strategy now? What do you think and do? I think so. The JCTO1, no previous attempt as well. So, okay. So, what's your
strategy? We're going to do with
PT2 polymeric, yes. Hydrophilic.
Yes, polymeric.
Do you think that's a good strategy, Rodolfo?
Yeah.
And what's the weight of this, the tip of this wire? About 2.7, right?
2.7.
So you think it's good? It's good to first one?
It's perfect. For this case, it's okay.
Okay. So what are you going to do now, Louis? About 45 degree minimum, the very, very tip. You could have the angio in the larger size and have here the operators in smaller side. Okay. So what are you doing now, Louis? So you think
retrieving a little bit because I thought it was going to the first diagonal, so I'm going to try to move back to the LAD here.
So you're not sure where you are distal, so you try to bring back a little bit.
It was in the first diagonal. So
yeah, and I can see you're being guided by the calcium, right?
Yeah,
as well.
Yes.
So that can help you to some extent. Okay, so now we see a collateral we haven't seen before.
I think we're perhaps in a septal, I don't know.
So you're going to bring back the wire a little bit and try to go, okay, following the calcium there. And
here.
Rodolfo, looks like the occlusion itself is just, just a more distal, right? Okay,
just cross the...
So it looks like just cross.
Yeah.
Perfectly done, smoothly, very elegantly. Yeah, so and now going to the LED.
Rodolfo tip a long time ago.
So Rodolfo, I think that's very important. So you had first working in the spider view where you can see the takeoff, the osteo, where the occlusion started, right? And then once you could advance, you just want to open the vessel to do invasive imaging to then discuss what will be your strategy.
Yeah.
Okay.
That's what I was
So which balloon did you use?
It's a 1.5 by 15.
1.5 by 15, so a lot of calcification there. You want to just make
Yes.
sure you're going to go through the lesion.
Smooth.
You're using here a
Okay.
PT2 with a hydrophilic wire for CTOs. They're going to do some nitro here. There appears to be a long segment, calcified. There's some, is a dissection there, maybe closer, or is a calcium there, external calcium, closer to the
First diagonal,
bifurcation.
yeah.
You check by IVUS first, right?
Yes.
Okay, so advance here with the IVUS catheter. I wonder here the ostium of the LED, if you have enough landing zone to just stay at the ostium, or if I have to go into the left main.
Yeah.
I'm very curious here about this. IVUS imaging interpretation. So we're starting here, distal to the bifurcation. We already see a lot of disease. Okay, now, okay. So we are here in the mid portion of the LED. It's a vessel about 3.0, 3.25. You already see disease here, diffusely disease. Calcium here between 5, now between, wow, a lot of calcium here. It's almost 270 degrees of calcium in this particular portion. Here about 270 again. I see superficial calcium. I see some deep calcium as well, more superficial. We are here more in the proximal segment, okay? And that's calcification throughout the entire segment. Plaque burden is really large, as one would expect. I see some micro dissections here due to the balloon angioplasty. We see the much larger vessel here, close to 4.0, the large plaque burden. Here's some dissection here at 9 o'clock. And definitely this condition will need some good lesion preparation. We are approaching here to the left main. You see the circumflex coming at 11. Disease, but not significant disease, left main. The calcified plate extends from 3 to 6 o'clock. And I see a large left main here, about 4.5, 5.0, barely no disease here, more close to the ostium, so we're going to stop the run here. To highlight here, this is the ostium of the LED, so you see the circumflex coming here at 11. You see that diffusely disease ostium of the LED, and we're going to come very close here to the ostium itself, so you cannot skip even a millimeter here at the ostium. And you're already in the left main here, so here is the LED, it's coming. Okay, I'm going here step by step. It's coming to the ostium. Circumflex is at 11 o'clock. And the plaque is really already into the LED.
Yeah.
So if you're able to stop there,
Yes.
maybe that's a possibility, or you have to go through the left main, and then you guarantee you cover the plaque in its full extent. And here you can see the vessel size, close to the bifurcation. We're talking about a 3.0 vessel. So in terms of lesion preparation,
Yeah.
if you want to have good preparation, maybe you should go with a larger balloon here. So can you have the angel back, please, to the main screen? The operators, Louis and Rodolfo, were able to cross with a hydrophilic PT2 wire, 2.7 grams. And they demonstrated the technique to make sure you are in the right lumen. All balloon dilatation, IVUS was performed, and we did see a disease that extends to the left main, even though it doesn't compromise, but there was no confidence that the stent to be deployed, the very ostium of the LED, give a satisfied result with the risk to have a dissection, some kind of compromise into the left main. So a decision has been made to have a longer stent from the ostium of the left main, or from the left main to the LED. Now, Louis advancing here a wire to the circumflex. So always another important tip to when you're dealing with a bifurcation, especially left main bifurcation with a large circumflex, an important side branch by definition, you should always have a wire there. Always have a wire there, because you're less likely to have an occlusion if you have a wire, and if you have to recross, that serves as a marker for you to recross and preserve patency throughout the procedures. Which wire did you advance to the circumflex?
Pilot 50.
We saw heavily calcified, a lot of black burden. You're gonna do some good lesion preparation here, right? So what are you planning to use here? So Rodolfo, 3.0 already, right? Because you can prepare the lesion well, very calcified. So 3.0 by 20 NC balloon, they're gonna use to prepare this lesion. Rodolfo, by what you saw there, so now Luis advancing balloon for lesion preparation non-compliant.
1, 1.
You want a 1 by 1 because so it's about 3.0, right?
Yeah.
So where are you going to start your dilatation, Rodolfo? Just proximal to the bifurcation there? Okay. So what you're doing here, you do an angel, Rodolfo, and then you take that die to help you. Very nice tip too. So what pressure are you now? Okay, so 10. It looks like a good opening, right? Good response. Based on this response, you feel comfortable
14.
to prepare the lesion only with the balloon. So you're going to bring more proximal now. 20 atmospheres, okay? Just for the LED, you're around 34, 36 millimeter. So you have a larger left main. Why 3.0, Rodolfo? So you consider to use 2 stents?
2 stents.
Okay. We're taking here. Okay. Okay, just advance the wire here again. Yeah.
Okay.
So we're gonna go here with 3.0 by 29 balloon, Cirrhosis coated balloon with ultra thin target technology. It's from Microport, the Firehawk, and a biodegradable PLA polymer. It's one of the mostly used DS in the world, and it's the #1 in China. So here, Rodolfo, you are advancing here.
The guy very
So you want to choose a working horse, right? Or you can advance also the PT2, right?
Yeah.
Get back to that same spot here. So now they're advancing here the stent, 3.0 by 29. So get some extra support there and try to be just at the bifurcation level. Just at the Austin, right? Yeah. Or maybe advance 1 millimeter there, right? Okay, so it's going there.
4,
They're at
5,
the very osteo location.
6.
And what pressure you want to go here, Rodolfo?
6.
So it's
Seven.
it's 1 by 1, right?
Yeah.
So
okay.
you don't feel you need to be more aggressive to deploy the stent. There's a good lesion preparation. That's why it was important to lesion preparation.
Pull back 2 millimeters.
Louis, you're gonna pull back just 1 or 2 millimeters, and you're gonna use the same balloon, Rodolfo, to post dilate. Okay, so what pressure do you go now? Okay.
The other stent and
I think it's,
go with a non-compliant balloon and postulate.
I think it's just perfect position. I think they're very awesome, very precisely at the Austin.
3.5.
Yeah. You can use the reference diameter. The left main is about 4.5. Okay, it will be a 3.5 by 15 to do an overlapping here at the osteo location, and then you're gonna have a stent into the left main. They are doing now. They are advancing here a second stent, which is a 3.5. And I think it's good to have a larger stent now, right? In the proximal segment. One stent only might make things a little bit harder. So you can do first, you pull a little bit, and then you can go to the larger balloon. Okay. The takeoff of the circumflex, yeah. Very important, right, Ruth? The manipulation of the guiding catheter to be very careful.
Do not
yeah. Okay, no, it's beautiful, 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 perfect positioning. So now 4.5 by 12 balloon is going to be chosen. Now we have here the balloon. Okay, so maybe you want to advance again to the wire. Yeah. Let us advance here. I think some testing here to see where you are. Okay, so need to be closer to the circumflex. Okay, I think a good position here. Let's do the balloon dilatation here in the stented segment and have the 4.5 by 12 for the pot.
Okay, but right. Push.
Okay, Rodolfo. So
1 millimeter.
Okay, so you're going up here, high pressure, right?
25.
25, okay. So now they are doing the post dilatation, optimizing the distance, which is also recommended to do everything you have to do within the stented segment, and then you can do the pot afterwards. I usually, that's what I do also in my practice. So really going up to pressure, right? 28,
30.
right, Rodolfo?
30.
30, okay,
Okay.
very good. So bringing back now,
The trio balloon.
and with a go to pot balloon now.
And we have a 4.5 by 12.
4.5 by 12, okay. See? Just make sure that you are in the right position here with the circumflex.
Um pouquinho mais.
Puxar o catéter um pouquinho.
Aí. Ok.
A little bit more. Okay. So I think you're in a good position. Okay, so going now. This is a 4.5 by 12.
Dá uma
And you
fumadinha,
can pull
deixa
to
eu-
have the flare, right,
Sure.
Rodolfo? The
Sure.
opening at the ostium. Okay, so you can pull a little bit more.
É.
So you went to the low pressure, and then now just make sure you're in the right position. Okay, now you can go high pressure. And then you can do the flaring, right, to the ostium.
Ok.
Yeah. You pull more, and you pull back the guiding catheter to have the flaring.
Yeah.
That's what you should do.
Let's
Okay.
take PCI angel here.
So that's a control angel. I tell you what, you could leave the circumflex like this.
Yeah.
Because it's fully open. After the pot, you see absolutely no compromise. That's a decision to be made. You can go recross and do a kissing. There is no clear benefit if you just leave it like this.
Aí
Of
você
course,
tem LID.
there's a concern to do if there progression of disease in the circumflex and you might have an opening there. I tend to do it, but there is no wrong here on leaving like this. If you have a TIMI flow 3, no compromise, no signs of dissection. Right, Rodolfo, do you agree? Okay, so we're going to do here control IVUS, and based on what we see, you decide what to do. So let's do an IVUS and take the entire segment. Mantém o flush, tá? Mantém o flush. Okay, good.
Okay.
That's good position. You can have the entire segment. Okay, we're just starting here, just at the bifurcation level. The septal, that's a diagonal here. There's some disease already there. You see a much larger vessel, of course. That's a distal dissection here between 3 and 6. And here, that's the distal transition of the stent. See a well-opening stent here. We have a large plaque body behind the struts. That's a calcified portion, a little bit less expanded here. You see, Rodolfo, now it's a vessel that's more than 3.0, right?
Yeah.
It's a much larger vessel. Come here to a larger portion of the vessel. Maybe here you could also post-dilate with a 3.5 vessel, because the vessel is really larger now, and that's the importance of using imaging guidance in this type of very complex lesions with CTO. Now we come here to the left main. We just saw here the entrance of the circumflex. It's incredible how is that well open. Because of the pot, well done and well positioned. So that's a very good demonstration of the efficacy of the pot. What we already recognize in angel, recognizing in the IVUS. So it's really good opening scaffolding there. And the stent is covering fully the ostium. Very precise position here, just enough. That's very nice. You guys should be congratulated. Very, very nice result, especially at the occlusion and at the bifurcation of the left main.
Some nitro.
So we're doing some nitro here.
The angel is good.
It's just a small flap distal there. Okay.
Not clinical.
I don't see a pinched circumflex as well, so I think it's very acceptable to leave like this and make sure there's no flow compromise. You can just leave like that. So I think this is a great result in a complex situation. Opening of a occluded ostium LAD involving a left main bifurcation. This patient had a multivessel disease, already had a subocclusive in-stent restenosis in the RCA, which was treated first. And now I think has a complete revascularization and has all the potential to have a very good, this lady has a very good clinical follow-up. So congratulations for you, Louis. Congratulations for the very tips.